Welcome to the lecture on common abnormalities of the newborn during our Step 2 highlight review of pediatrics. We're going to go over amniotic fluid abnormalities, abdominal and GU abnormalities. Before getting into the abnormalities of amniotic fluid, let's review the more general aspects of it. So amniotic fluid is the stuff that the baby floats around, and 80% of it, the bulk of it, is produced by the mother and the placenta. Only 20% of it is produced by the infant, but that doesn't mean problems with the infant aren't going to lead to dramatic changes in the amniotic fluid amount and content. So something to keep in mind is that the amniotic fluid produced by the infant is largely made via urination. So keep that in mind because any anatomical or functional kidney or GU problem is going to lead to problems with amniotic fluid production. So the problems with amniotic fluid largely come in two flavors. You either have too much amniotic fluid, which is called polyhydramnios, or you have too little amniotic fluid, and that's oligohydramnios, and they have different causes and different consequences. We're only going to spend a little time on both of these topics because while they will show up on your test in some form, it's not likely that you're going to be tested in great depth on them. You're not going to be asked how to identify polyhydramnios or oligohydramnios. They're not going to ask you to calculate an amniotic fluid index, which is the process by which they actually decide and establish the presence of too little or too much amniotic fluid. What you do need to know are the conditions associated with amniotic fluid abnormalities and what we do about it. So as we said, polyhydramnios is when there's too much fluid, and this happens with either too much produced or too little resorbed. And this can happen in several ways, but it's most often related to central nervous system problems or GI malformations of the unborn fetus. So in CNS malformations, what we think happens is that there's either increased production of fluid via overurination, so there's some kind of signaling or lack of signaling that's causing the fetus to continue to urinate, which produces too much amniotic fluid. Because remember, 20% of all amniotic fluids via the fetus, or there's literally fluid exuding through the exposed meninges, as you can see in these pictures of myelomeningocele and myeloceles. Now, to be clear about polyhydramnios, severe polyhydramnios is often associated with malformations. So if you see severe polyhydramnios, then you can almost be certain that there's a congenital malformation of that child. But the reverse is not necessarily true. There are dozens, hundreds of problems that occur in unborn children that don't have anything to do with amniotic fluid abnormalities, so don't necessarily link the two. In GI malformations, particularly esophageal atresia, there is a blockage of the swallowing of the fluid by the baby. So part of the way that the amniotic fluid is balanced in utero is that the entire GI tract of the fetus serves as a reservoir of amniotic fluid throughout gestation. And if you have a blockage of the esophagus, that means the amniotic fluid can't get into the GI system, and therefore it's all kept external to the baby, and that can be a major issue. So here you have three different types of esophageal atresia, type A being the most common, but this is to give you an idea that if that esophagus doesn't connect to the GI tract, you can see that it's going to cause a buildup of amniotic fluid external to the child. Oligohydramnios, on the other hand, is too little fluid production and a low AFI. And this is almost always related to underproduction, which we'll cover right now. So the most common cause of oligohydramnios in pregnancies is actually when the pregnancy has gone on too long, a post-term pregnancy. So anytime the gestation goes past 40 weeks, you have to start doing more frequent ultrasounds to look for oligohydramnios, and that's because the placenta is past its due date. It's ready for the pregnancy to take place. So if the placenta starts to wear out, given that it's responsible for 80% of the amniotic fluid production, you can see that it starts to take a steep dive in fluid amount if it starts to wear out. Another cause related to underproduction would be renal agenesis or renal failure in the unborn child. So like we said earlier, that urination by the child makes up 20% of the amniotic fluid amount, and so if you don't have kidneys or you have kidney failure in this fetus, then you're going to have too little amniotic fluid around them. Now, we're not just concerned about oligohydramnios because of the conditions that it's related to. We're actually concerned about oligohydramnios in and of itself, and that's because it leads to an increased risk of cord compression. Now, cord compression leads to lack of oxygen supply to the baby and its brain and can be deadly and or long-term problems. So it's worth noting because it's a major reason, cord compression is a major reason for inducing labor or performing a C-section in a woman who's otherwise fine, and a baby that's otherwise fine. Because if you see too little amniotic fluid for that baby to float around, you know that cord compression is not something worth risking, especially in a pregnancy that's post-term. I mean, we know the baby's lungs are probably going to be fine, so just deliver it to avoid this potential problem. A tip. There are two things I want you to commit to memory right now, and I'm going to pose a couple questions to you to hopefully solidify these in your long-term memory. So, what class of antihypertensives is never given to a pregnant woman because it's risk that leads to congenital abnormalities? ACE inhibitors. So ACE inhibitors can lead to renal agenesis, and thus in women exposed to ACE inhibitors that are also pregnant, you need to frequently do ultrasounds to check for oligohydramnios, because you can't always see if the little kidneys are working in a child. Sometimes the kidneys are so small in a fetus, you can't see them on ultrasound, but what you can see is whether there's enough amniotic fluid. And if there isn't, then you have a strong reason to believe that this child's suffering from renal agenesis. It's going to have long-term problems. Next question. What syndrome, congenital syndrome, is associated with oligohydramnios secondary to renal agenesis, pulmonary hypoplasia, and abnormal facies? That sort of combination of things. Renal agenesis, pulmonary hypoplasia, abnormal facies. Write it down because it's Potter syndrome. So try and commit these two facts to memory because they don't really come up in many different flavors on your test. All the questions related to ACE inhibitors in pregnancy and Potter syndrome tend to be the same. Moving on to abdominal abnormalities, let's start with the vignette. A premature infant is born at 28 weeks in respiratory distress with grunting, nasal flaring, and the use of accessory muscles. Bowel sounds are heard on auscultation of the back, and a chest x-ray shows air fluid levels in the chest. So what are air fluid levels? Which of the following is the most likely diagnosis? Not a possible, the most likely. Hydrocele, gastroschisis, diaphragmatic hernia, hiatal hernia, or omphalocele. Here's a chest x-ray that could be associated with the vignette and presentation that was just described. Note the large loops of dilated bowel, the air fluid levels in the chest cavity seen below the rib cage. The best way to answer this question, like every other question we're going to do in our Step 2 High Yield Review, is to not just know what's right, but cover what's wrong and why it's wrong. So the correct answer here is diaphragmatic hernia. This might seem straightforward, as it's a hole or defect in the diaphragm, because that is certainly one way you can get bowel into the chest and why you'd hear bowel sounds on auscultation of the back or even the chest. That is the big clue here. On the test, they tend to be a little more vague, just giving you the respiratory distress and maybe the x-ray, but not necessarily providing you the findings on auscultation. That's why you should take a good look at the image provided prior to this so that you can recognize this without the telltale findings in the question stem. The respiratory distress described in the vignette is secondary to pulmonary hypoplasia. We'll go over that in more detail in just a moment, but let's finish ruling out the rest of our answer options. So a hydrocele, I hope you remember from your urological lectures, because that's a urological issue. It's too far south to be a respiratory issue. Gastroschisis and omphalocele are both abdominal wall defects, so they lead to your gastric contents ending up in the amniotic space, but not in the chest cavity, so they would not lead to respiratory distress. They're an entirely different issue. And the hiatal hernias are really seen in adults. They're a common cause of GERD and not the answer here. Let's focus more on diaphragmatic hernia for just a moment. Adding to our conversation on diaphragmatic hernias, I want to emphasize a few points. The first is, this is a congenital defect of the diaphragm. They're born with it. It's there in utero. It's just not an issue in utero because they're getting all their oxygenation from their mother via the placenta. Next is that there are two types, eponymous types of diaphragmatic hernia, named after someone named Boch-Deleck and Moriani.
But if there's a name worth remembering, it's the first one, and that's because Bochdalek hernias are the most common type that do occur. So B comes before M, maybe you'll remember that that's first, and then remember that these occur most commonly on the left side. Now, why these happen, the cause of these hernias is actually unknown. So we're going to focus on the key findings of an individual, of a baby that has a diaphragmatic hernia, and how you identify that and what are you going to do about it. So the key findings are similar to what we saw in our vignette. Respiratory distress. You've got the bowel is in the chest cavity now. It's been sitting on the lungs, inhibiting their development. So they have pulmonary hypoplasia. And because of this respiratory distress, they develop a scaphoid abdomen. So they can't breathe in as well as they should. So they're using their accessory muscles as much as they can to pull their chest wall out. The pressure, the negative pressure that develops within the intrathoracic cavity from the forcing of that expanding chest wall causes the abdomen to get sucked in. There's a hernia there now, so the pressure within the thoracic cavity is now going to be connected to the pressure within the intra-abdominal cavity. That causes the abdominal contents to move up into the chest cavity, and you get a scaphoid abdomen. There's also bowel sounds heard in the chest. That's probably the pathognomonic sign as far as step 2 is concerned to think about diaphragmatic hernia. And then there's an abnormal chest radiograph. You see loops of bowel where the heart normally is or where the lungs should be. It pretty much gives you an idea of what's going on. Now, the real money is, what's the first step in management? What are you going to do? And the answer is not surgery. The answer is not going to be running labs. Those are never going to be the right answer because what is going on in the situation? Respiratory distress. You have to secure the airway. You have to make sure this kid can oxygenate. So the first step is securing the airway via intubation. You've got to get a tube down there and you've got to get 100% O2 going into those lungs so that baby can oxygenate. Once you clamp that cord and they start to try to breathe, they're in big trouble because they don't have lungs to oxygenate their blood. So you have to help them as much as you can with intubation. In my opinion, any discussion of omphalocele and gastroschisis occurs together because these two concepts can easily get confused because there's a lot of similarities, and it's just some nuances that make them different, and you'll have to know those to differentiate them on the test. So, starting with what they are. Well, they're both wall defects, which means that in utero, the abdominal contents of the fetus, the intestines, the stomach, the pancreas, they all develop in the amniotic fluid space, in the amniotic space outside of the abdominal wall, but not in the same way, not for the same reasons. But so in omphalocele, it's a midline wall defect, sort of right through the umbilicus. And so use the O, it's like beautiful central symmetry to remember that that is the midline defect, or gastroschisis is a lateral wall defect. Now, the next major difference is the presence or the absence of a sac. So in omphalocele, using that O again, kind of looks like a sac. The abdominal wall contents are developing in the amniotic space, but they're in a sac, which is not the case in gastroschisis, where it's just all those organs are just free-floating in the amniotic space, developing on their own, without a sac. And then the next is the major association. So for gastroschisis, it's atresias. And for omphalocele, it's a series of things. It can be an imperforate anus, which is a type of atresia. There's a lot of congenital heart defects, and they also tend to be associated with several types of trisomies, but in particular trisomy 18, Edwards syndrome, is another important association, as well as conjoined twins and Beckwith-Wiedemann syndrome. Now, as far as the treatment of these two things, it's going to be the same, and that's surgery. So I don't think that knowing what to do, obviously surgery is necessary. No one can live a normal life with their abdominal contents, all of them hanging out outside. They got to be put back in, and these are extensive surgeries. So highly unlikely they're going to be like, what's the end result for treatment for these children? Because surgery is the obvious choice, and so that's not going to be your question on the test. It's going to be what differentiating the between these two and probably linking the associated syndromes with them.
Some tips with abdominal abnormalities. So, an elevated AFP, alpha fetoprotein, can be used to screen for abdominal wall defects, just like it's used to screen for neural tube defects. Really, any defect that exposes the contents of what's inside the fetus to the amniotic space will lead to an elevated AFP. Recall that after the first trimester, alpha fetal protein is largely made in the fetal liver and the fetal GI tract. Thus, if our fetus GI tract is swimming around in the amniotic space outside the abdominal cavity, more of the AFP is going to be in the amniotic fluid, and therefore expose the placenta and getting into mom's bloodstream, leading to an elevated alpha fetal protein level. But don't forget that the most common cause of an elevated AFP is actually incorrect dating, meaning if you measure a pregnant woman's AFP at 21 weeks, but you think they're 18 weeks, you'll incorrectly find their AFP elevated. So while abdominal defects are a common cause of elevated AFPs, they're not the most common cause. That's incorrect dating. The last tip is related to umbilical hernias, which are very similar to omphalocele, meaning that they're midline and they have a sac. But the key difference is that umbilical hernias are always smaller than 4 centimeters, and they almost always close on their own. Any discussion of abdominal abnormalities is going to have to touch on tumors, and so we're going to cover the most common 2 tumors seen in the abdominal region in children, starting with Wilms tumor. So just focusing on the highlights, Wilms tumor is highly tested because it's actually incredibly common, as the most common primary renal malignancy in children. So it's not the most common primary malignancy. It's not even the most common renal malignancy, but it's the most common primary renal malignancy in kids. The presentation of Wilms tumor usually goes something like this. Mother brings in her 18-month-old son after noticing a large flank mass while bathing him the night before. Doesn't seem to bother him, but on further review, she has noticed that her son has had some difficulty passing stool recently, and she's even suspicious of some darkening in his urine. On physical exam, he's found to have a heart rate of 110, a BP of 120/70, and respiring comfortably at 30 breaths per minute. You also notice the absence of an iris, but otherwise the physical exam is unremarkable, and even on palpation of the abdomen, there doesn't seem to be any pain. This is the more classic way that Wilms tends to present, and it drops all the pearls without giving you a clear diagnosis, but it's a dangerous malignant tumor in a young child with relatively few symptoms, and that should actually really trigger Wilms to you. The hematuria is only seen in 30% of cases, so don't count on that being in your vignette. The first test you order with this presentation is, remember this is pediatrics, so go for the least invasive if you can. It's going to be an ultrasound. And because if it's a flank mass, it's pretty close to the surface, and children have less fat around their body, so you can get to the tumor relatively easy in these kids. But once you suspect something suspicious on abdominal ultrasound, the most diagnostic test, the best test to confirm the diagnosis is going to be a CT. And this is for 2 reasons. Now, CTs will give you a better visualization and understanding of the degree of the primary tumor itself, but you can also evaluate for metastases in the lungs with the CT, because the most common place that a Wilms tumor metastasizes to is the lungs. And then in many syndromes are associated with Wilms tumor, and in step 1, I'm sure that there was a lot of emphasis on Wager, Dinsdrash, Beckwith-Wiedemann, but I do not think these are worth your time for step 2. Focus on the presentation, focus on the 2 tests you're really going to order, and which one you're going to order first, and which one you're going to order if you want the clearest of diagnoses, and then focus on the management. In the case of Wilms tumor, it's a trifecta: surgery, chemo, and radiation. So focusing on the 3 things you got to take away from Wilms tumor, it's the first step you order, ultrasound. The most diagnostic test to confirm your diagnosis, that's going to be CT. And what are you going to do about it? You're going to do all 3 of these: surgery, chemo, and radiation.
I want to quickly discuss neuroblastomas because they are quite common in children. Different texts will convey this commonality in different ways. Some will say it's the most common solid tumor in children. Some will say it's the most common malignancy in infants, or that it's the most common extracranial tumor in kids. What I mean to say is don't stress out knowing to what degree this tumor is the most common. The whole point is that we're all trying to convey that it's very common and therefore very likely to show up in your test in some way. But you need to know that it's a very common tumor in children, and it usually involves the adrenal gland, but it's not an adrenal tumor. It's a tumor of the sympathetic ganglia, and those can be found all over the body. This one just most commonly tends to be found in or near the adrenal gland. Now, how it presents is critical because we want to distinguish it from Wilms tumor, which is another common tumor that occurs in the abdomen of children, and that is this is a painful abdominal mass. Something I want you to pay particular attention to because Wilms tumor is painless. It also presents with neurological findings. You might see this name pop up, opsomyoclonus. So there can be random eye movements and jerking movements, and this can trick you into thinking it's a neurological disorder. But if you see neurological findings with an abdominal mass, particularly a painful abdominal mass, you should start thinking neuroblastoma, even if you can't remember what the exact associated neurological findings are. But neuro findings, abdominal mass, you got to start thinking neuroblastoma, especially in a kid. Diarrhea is another big component. So this diarrhea tends to be secretory, and it's secondary to the release of a vasoactive intestinal peptide, which is also seen in VIPomas. It's a profuse diarrhea that can also lead to hypokalemia because the secretory diarrhea leads to increased flow through the GI tract, and that causes the flow to pull potassium from the system and out into the stool. So hypokalemia can also be seen in those kids as well as accompanying their diarrhea. So diagnostic key features is you got to look at urine catecholamines and their metabolites. That's great because in this population we want to see non-invasive tests when we can, and you're looking at the urine is really helpful. And 95% of children with neuroblastomas are going to have elevated VMA, which is vanilla mandelic acid, or homovanillic acid, HVA.
The last topic of this lecture is going to be a brief mention and discussion of GU abnormalities. Now, these aren't tested to great lengths on the test, but there are a few, and we're going to go over 4 here, that do pop up in various ways, and they're easy to get right, and so I want to make sure we clarify some of the confusing aspects of them. So starting with hydrocele. Hydrocele is a painless, benign fluid-filled sac, and an important clinical maneuver, and something you might see described in your vignette, is that it transilluminates, meaning if you shine a light behind the mass, light will shine through it, which is not true of varicoceles, which is dilated veins, or sacs filled with blood, or tumors. So if a child comes in with a painful or painless mass in the testicular region, you can just throw a light behind it, and if it transilluminates, it's most likely to be a hydrocele. And if it is a hydrocele, and it's not painful, and it's just painless, then you don't need to do anything about it. It often will recede on its own, and there's no real risk with it. But sometimes it can be uncomfortable, especially if it's impinging on the veins, or it can just be uncomfortable to the child, or maybe the parents don't like that it's there, in which case you can simply drain it, and that's an easy enough procedure. The next is cryptorchidism, and that is when there's undescended testis. Now, the reason this is a commonly tested topic on step 2 is that those with cryptorchidism are at increased risk of cancer later in life. Now, an important note to make here is that cryptorchidism doesn't cause the increased risk of cancer, but those who have cryptorchidism are at increased risk of cancer. Now, what's important to note is the timing. Now, it's not uncommon for a 2-month-old or 3-month-old boy to still have an undescended testis. But as it goes on, and if that testis doesn't come down on its own,
the majority of which will come down at 6 months. If it doesn't come down after 6 months, then you have to do a surgical procedure to bring the testis down into the scrotum, and so it can be observed. Now, the reason this is important is that of those children whose testes don't descend on their own and need surgical correction, there's something going on there. There was something going on in the development that led these testes to not descend. And that same reason makes them an increased risk of developing testicular cancer, particularly seminomas. Now, this is also something to keep in mind. Usually, it's just one testis that doesn't descend. But those children who have at least one testis that doesn't descend after 6 months are at increased risk of seminomas in both testicles, whether they descended on their own or not. And that goes back to this issue that cryptorganism is related to a problem with development. And that same developmental issue places them at increased cancer risk. It's independent of the testis actually moving down. It's related to the underlying cause of why that testis didn't come down. And that underlying cause also increases their risk of seminomas. So they can get testicular cancer in either testis. And so we bring the testis down surgically into the scrotum, not to prevent the cancer, but to make the cancer easier to screen for, which is through physical maneuvers. One of the last two things we want to go over is hypospadias, which is simply a ventral surface opening of the urethra, and that's surgically corrected. And the sort of opposite of that is epispadias, which is a dorsal surface opening. And I only put these on here so that you remember that hypo is ventral, epi is dorsal, and they have the same procedure that's required of them in that surgery.